This chapter will be covering topical agents. You'll notice when you opened to chapter 13, there was an almost overwhelming list of medications listed on the first 2 pages. It is not my intention that you memorize all of the possible agents that are used to treat dermatologic issues. As we move through this PowerPoint, you're going to be asked to focus on your favorite, if you will, in each of the categories that we cover. That will make you a successful nurse practitioner in practice because you will understand how to use these agents and how to deviate from your favorites if necessary, but you won't be bogged down and overwhelmed by the endless possibilities to treat topical issues. Having a short understanding of the anatomy and physiology of the skin will help you understand how topical agents work. We know that the skin functions primarily to protect us from the world and the things around us. When we think about the skin, it consists of 3 distinct layers: the epidermis, the dermis, and subcutaneous tissue, the subcutaneous tissue being the deepest layer of these 3. The epidermis is the most superficial in that it is the skin cell level. This is where we have skin cell turnover. If we are sloughing of our skin, this is the layer in which that takes place. The dermis, the next level, contains the nerves, the blood vessels, the hair follicles, and then the apocrine and eccrine glands. Those are part of our secretory glands that regulate a lot of what happens on the surface or the epidermis of the skin. The subcutaneous tissue then provides the padding and insulation that is necessary to protect and support and maintain the structure of the underlying structures. Topical agents come in a variety of dosage forms, and you're going to select an agent based on what characteristics you want the product to possess. Creams are white in color and somewhat greasy. Creams are probably the most common form that we have topical products dispensed in because they can be used on nearly all parts of the body. They're especially useful in areas such as the groin or genital areas, the axillae, aka the armpits, or the intertriginous areas, areas where 2 folds of skin come together. However, they can be drying after prolonged use, so some patients may initially have a response to them, but then almost exacerbate their issues because excessive or long-term use can actually dry the skin, thus leading to more issues with itching, rash, those types of things. And they are best used for acute exfoliative dermatitis. Ointments, on the other hand, are translucent or see-through. They do have a persistent greasy feeling. So creams, while they are somewhat greasy, you can basically rub the area enough to absorb the cream to a maximal extent, whereas ointments are going to leave a greasy, slippery feeling, if you will, on the skin. They do have enhanced penetration, however. If we're thinking about which agents get into the layers of the skin the best, ointments are very high up there. Their enhanced penetration leads to enhanced potency, so we can typically use these for drier lesions. We will sometimes see ointments being used for issues like psoriasis. Those issues are dry, or those areas on the skin, are dry and plaqued over, and so ointments have better penetration of that hardened skin. Oftentimes, ointments are too occlusive for the intertriginous areas, meaning that they don't allow the areas to breathe. So if you think of the area between your toes, that's a webbing of the skin that's close together. If you put a lot of ointments there, they're going to be greasy and they're a breeding ground for hot, stinky germs that might also live on your feet. Gels are clear and gelatinous in consistency, as the name would lead you to believe. They have a generally very sticky feeling. So ointments are greasy and slick. Gels give this feeling that there's a constant stick or a need to wash it off. Alcohol-based gels feel cool and are drying. Those are useful in situations like poison ivy. Non-alcoholic gels are more lubricating and are often used in scalp lesions. Lastly, solutions and lotions. These can either be clear or milky in appearance. These 2 types of formulations are often most useful for scalp issues because these are the types of formulations that can penetrate the hair shaft. So sometimes if people have significant dandruff issues or other drying of the scalp issues that over-the-counter products don't treat, we will see solutions or lotions that are applied after shampooing or before bedtime, things of that nature. Treating skin lesions is unique when we think about it in respect to any other sort of disease state we're going to be treating as practitioners. You actually visualize the lesion or issue or rash that you're treating on the skin, you pick an agent to treat, you apply the agent, and then you can actually see in real time the response of that lesion or issue to the product that you've chosen. So it's really important to understand the mechanism of action of the agents that are used to treat topical issues. The first one we're going to focus on is topical corticosteroids. They work by diffusing across the cell membranes and inducing cutaneous vasoconstriction. So the more potent the corticosteroid is, the more vasoconstriction that's going to result. Thus, we have high, medium, low, and OTC potency corticosteroids. Vasoconstriction leads to local anti-inflammatory effects. So we decrease histamine, we decrease inflammatory mediators, we inhibit macrophage and leukocyte migration to the area. And the thing to remember when thinking about topical corticosteroids or any topical treatment agents is that there are no standardized guidelines or specific agents for various diseases, and there are no evidence-based guidelines. So the selection of the agent that you're going to use in practice, like I had mentioned earlier, is going to be your favorite. Maybe it's something that you've seen your preceptors in your clinical rotations use, and you've just kind of used that as your own frame of reference, or maybe you've done a little other personal research or family research and you know kind of which agents have worked better for yourself or family members. When we initiate therapy with a topical corticosteroid, we should choose an agent of the lowest potency needed to treat that issue and use it for as short of a duration as possible. When we're treating areas that cover large portions of the skin, we should focus on treatment with a mild or intermediate strength agent because the likelihood of systemic absorption when we're treating a large surface area of the body is higher than if we're treating just a small lesion on the face or the scalp or a particular extremity. In practice, we often see patients prescribed a course for a scheduled duration, followed by directions for use as needed. For example, in the hospital setting, if we have patients that have very severe red itchy rashes, they will be prescribed a medium dose or medium strength topical corticosteroid like betamethasone, and they will apply that maybe daily or up to 3 times a day for 2 weeks, and then they will give it a rest, see if the lesion has cleared up or if the itching and rash has subsided, and then they will have instructions to use as needed. So whenever there's a flare-up, I'll have patients tell me, oh, when it's really dry in the winter, I'll need to use it more often, or if I have exposure to the sun and my skin dries out, I might need to use my agent more often. Important directions for use for a patient that they can understand is very necessary when we're using topical corticosteroid agents. We don't want patients to overuse them. We don't want them to become tolerant to the agents, and we don't want to set them up for additional issues. If you'll recall, we talked earlier about creams sometimes being excessively drying. So if you're using a topical corticosteroid cream to help a patient treat a rash, itchy area, and we use it for too long, we will then excessively dry the skin and exacerbate their initial issue. Oftentimes when we're using very high potent or high potent topical corticosteroids, we will need to taper to help prevent the recurrence of the skin condition. So we talked a moment ago about using the agent for a defined period of time and then stopping it. If we are treating an agent with a very high potent corticosteroid, if we immediately stop that agent, we will not have suppressed the lesion enough that it will flare right back up. So in those settings, we're going to want to use a very high potent corticosteroid, taper down to a high potency corticosteroid, and then live with a PRN medium use potent corticosteroid. So the tapering is best performed by gradually reducing the potency and the frequency of use and doing so at 2-week intervals. The topical corticosteroids are ranked according to their potency, and when you look in your textbook on page 154, there is a table 13.2 that shows you the groups 1 through 4. Those are the very high to low potency corticosteroids. The corticosteroids are then further categorized on page 155, not in table form, all the way to group 7. So group 1 is the most potent, group 7 is the least potent. That's very nice. However, it's probably easier for us to think about them just very simply as high, medium, and low potency corticosteroids. Practitioners often prescribe lower potency agents because they are felt to be safer. However, an adequate strength is necessary in order to achieve a therapeutic response. If we use a low potency corticosteroid for a long period of time to treat a dermatologic issue, we are in essence just diluting the issue or diluting the problem and never really solving the problem or curing the dermatologic issue. So it's important to pick an agent that's going to effectively treat and to do maybe shorter bursts with a higher potency agent, which will be more effective and potentially cause fewer adverse effects than just this sort of continuous suppression with a low potency corticosteroid treatment. Weak over-the-counter hydrocortisone is typically not effective against many of the agent or conditions that affect the skin, nails, hair, or glands, which collectively are called dermatoses. Medium potency steroids, or those steroids that are from class 3 or 4, are often more effective, especially when we use them as a burst or a short course of therapy. The use of low potency agents is appropriate in children. It's appropriate when we're treating large areas of the body because, again, we are worried a little bit about systemic absorption. And it's also necessary or appropriate to use low potency agents on body sites that are prone to corticosteroid damage, such as the face, the scrotum, the axilla, flexures of the skin, or skin folds. We don't want to exacerbate those areas that are sometimes more thin skin, delicate skin, or skin that does not get a lot of good airflow circulation and could be a breeding ground for other problems if we're continuously occluding them with a topical agent. As a note, no fluorinated or high potency agents should be used on the face. Super potent corticosteroids or very highly potent corticosteroids like betamethasone dipropionate ointment or clobetasol propionate cream should not be used for longer than 2 consecutive weeks. Sometimes patients do need to do cyclic or pulse dosing, so they'll need to alternate between 2 different super highly potent corticosteroids, but if they're going to do that, they cannot use one agent within the week of another. So it's almost like you need to have an on-off period if you're going to have to do cyclic or pulse dosing of super potent corticosteroids. How often do I think you will see this as a nurse practitioner in your practice? Not very often. I think these issues are probably more commonly managed by a dermatologist. However, it's good for you to be in the know in the event that a patient walks into your clinic, has told you some of the things they have tried. At least you'll be able to know when to refer them to another level of care. Just some food for thought, betamethasone dipropionate products cannot be used under occlusion, meaning you cannot apply that agent and then wrap it with any sort of ACE wrap or bandage or gauze, because those agents are just too potent and too strong, and they will actually, if they are occluded, will cause damage to the epidermal layer. Sometimes we can see renal suppression in patients that are on long-term high-potent topical corticosteroids. So what that means is that the topical corticosteroid is so potent that it actually causes a systemic suppression of our own ability to create our systemic steroids that kind of cruise throughout our system in times of stress, in times of daily function, circadian rhythm, those types of things. So if a patient walks into your office and is on a super potent corticosteroid agent and is having symptoms that maybe alert you or throw up a red flag for you, you may want to monitor their HPA suppression or the suppression of their systemic steroids. Later on in the semester, we're going to talk about systemic steroids. So it's all right if you're not completely up to speed with what I'm talking about at this moment. We will kind of revisit this when we're talking about systemic steroids later in the semester. Group 6 and 7 are the lowest potency, and really I'm just going to consider those over the counter. They're not strong enough to treat a lot of the conditions that patients are going to wander into your offices with complaints for. If we think of hydrocortisone cream that you can just buy at Hy-Vee or Walgreens or something along those lines, that's for if you get into some weeds in your yard or you just have a flare-up of a rash. Something that you can treat at home is when you're going to want to let a patient know that they can use the over-the-counter products. This slide is going to cover some general information for counseling points you can provide for your patients about the use of topical corticosteroids, and a little bit of a discussion about dispensing the appropriate quantity of topical corticosteroids. So typically we will tell patients to apply these products sparingly 2 to 4 times a day. Adequate results are usually achieved with just twice daily application, but sometimes initially patients will feel better applying it more often, so up to 4 times a day. The usual course of therapy for a topical corticosteroid agent is anywhere from 2 to 6 weeks. Close follow-up with the patient is necessary when an agent is started because if the desired results are not achieved in about 4 to 7 days or about 2 weeks, 4 to 7 days is a good check-in point. 2 weeks, if they've seen no improvement in their condition, they're going to want to stop the agent they're currently using and try a new one. Giving themselves a couple of day break, however, so that the previous topical corticosteroid is no longer in the system and the new topical corticosteroid can exert its effects. You want to, as a practitioner, dispense an appropriate quantity of any sort of topical agent that you prescribe for a patient. A lot of times we run into problems of the practitioner not having a good idea of how much to dispense, and so we see both ends of the spectrum. Way too much, thus way too costly for the patient, or not nearly enough, therefore inadequate use by the patient because they're worried that that's all they're going to get is a tiny 15-gram tube, and so they're not applying it as liberally as they should be to the affected area. So in your textbook on page 153, there is a diagram that talks about the rule of nines, and it's a picture of the human body, and it shows you roughly how many grams are needed to cover an area of the body if you're doing daily application. I think this is a wonderful chart for a practitioner to make a photocopy of and keep in maybe their external brain is what I'm going to call it, so that they can reference it, making sure that they're always prescribing the appropriate amount of product for their patient. Triamcinolone is a commonly used agent because it is available generically and it is available in a variety of strengths. So there's a take-home message for you. Triamcinolone is a great steroid to keep in your think tank when you're needing to treat a topical problem for a patient. Triamcinolone 0.5% is a good medium strength agent. It's effective for many of the rashes or complaints topically that are seen in the office setting. And then based on where that is on the skin or how thick the skin is that you're treating, you can choose to dispense it as an ointment or a cream. One of the other reasons that we monitor or reevaluate patients is to make sure that we're not causing super infections. Geriatric patients are more susceptible to super infections, and that's when we've suppressed one portion of the skin so much that we allow other issues to kind of come to a head or be created. Topical corticosteroid agents are not useful in skin conditions that are primarily bacterial infections like rosacea, cellulitis, impetigo, or acne. So that's just food for thought because sometimes these things can look similar, but we need to know what we're treating so that we pick the best agent. Our next slide I will not be speaking on, but it is just a slide with pictures of the various product sizes to kind of give you a visual of how topical agents are prescribed. Now we're going to switch our focus to topical antibiotics. So when we're treating skin infections now, topical antibiotics are useful because, again, we can see the issue, we can treat it with a topical antibiotic, and then we can actually gauge how well we've cured that complaint. Gram-negative infections of the skin are relatively rare. More commonly, we're going to see superficial infections that are caused by beta hemolytic streptococci, Staph aureus, or strep pyogenes. So an agent that I think you should keep in mind when you're thinking about topical antibiotics is mupirocin or Bactroban. It comes as a 2% cream or ointment, and it is typically applied 3 times daily. The medical terminology abbreviation for that is TID. Bactroban or mupirocin is commonly used to treat impetigo, so that's something that will affect children. We see it a lot in daycares. It's like a crusty bacterial rash on the skin. And then we can often also use Bactroban as part of a decolonization regimen for patients who are carriers of MRSA in the nares. So before patients come in to have orthopedic surgeries at our hospital, they get a nasal swab for MRSA, and if their nasal swab is positive, they will use Bactroban ointment in their nose. I believe it's 5 days prior to surgery or for a 5-day course to help decolonize them for MRSA so that that does not spread then to their surgical site. When we use topical antibiotics, we need to reevaluate the use of the agent if there is no improvement in 3 to 5 days. We should start to see improvement very quickly when we're using a topical antibiotic agent. If we use topical antibiotic agents for too long, we can get bacterial overgrowth, and that will result in superinfection or can lead to fungal infection. So in terms of duration of therapy, it's very important to counsel patients to exactly how long they need to use these and to enforce calling back to the office if improvement is not seen within that 3 to 5 day period. Sometimes when we use topical products, we might see like a product in combination with a corticosteroid. That would be inappropriate in the setting of topical antibiotics. And that makes sense for the following reason. Topical corticosteroids are used to suppress the inflammatory or infectious mediators in the skin. By nature, if you decrease the inflammatory mediators, then you're decreasing the macrophages and the leukocytes, or those other things that we call to the site when we need to fight an infection. So if you have a topical bacterial infection, we don't want to suppress your body's ability to fight that infection and call the right players to the site. Fungal infections can occur in almost any part of the body. Tinea fungal infections are those originating from the skin or nails. Candida species are yeast-like infections. Candida albicans is a fungal organism that can affect skin folds and the groin. So there are some over-the-counter products that patients can use to treat or to initially try to treat some fungal issues. Lotrimin or clotrimazole 1% is usually reserved for tinea pedis, or athlete's foot, if you will. Miconazole or monostat is available over the counter, and that's commonly used for vaginal candidiasis or yeast infections. And the over-the-counter products are available in a variety of dosage forms, such as creams, suppositories, ointments, and powders. So a lot of times patients will have already tried these agents before they present to your office. However, if they have not tried these agents and they present with a common case of a athlete's foot, or if it's one of their first issues with a yeast infection and they don't have a lot of other comorbid conditions or disease states that might predispose them to yeast infections, you can certainly recommend using an over-the-counter product. Prescription products include ketoconazole or Nizoral. That is used for fungal skin infections or scalp fungal infections. The cool thing about Nizoral is that it does come as a antifungal shampoo. Terbinafine or Lamisil is commonly used in cases that are resistant to over-the-counter treatment for athlete's foot. So terbinafine is kind of like your next step if you have failed outpatient Lotrimin. Nystatin then, or mycostatin, is used for the candida infections either in the mouth or of the skin fold. So these again come in a variety of dosage forms, powders, creams, or oral solutions. So one of the things that jumps to mind is patients that maybe have had chemotherapy regimens. They'll often have fungal infection complaints of the mouth, and we will typically see them use an oral solution of nystatin as a swish and spit or swish and swallow formulation. And then any of you who have had experience in the hospital setting have probably applied at least your fair share of nystatin powder to patients that have skin folds or other areas of the skin that don't get good air circulation. In using topical antifungals, both the over-the-counter and the prescription products are applied either once or twice daily, and the duration of treatment really ranges anywhere from 1 to 4 weeks. You have to treat generally long enough for the complete turnover of the skin to occur after the symptoms have resolved. So it's not uncommon for people that maybe have nail fungal infections to have to use treatment until that nail has completely grown out, so that you have completely new nail generated in the spot of the nail that previously had the fungal infection. It is not uncommon to see antifungal agents combined with a corticosteroid. So we don't combine topical antibiotics with corticosteroids, but we do often combine topical antifungals with corticosteroids, and the most common combination product is clotrimazole with triamcinolone. And we use that combination to help relieve the itching and inflammation that accompanies a topical antifungal infection. Out of all of the fungal infections, athlete's foot or tinea pedis takes the longest to clear, usually about 4 weeks. All of the azole antifungals, so if you ever look at a chart or a book, anything that ends in azole is an azole antifungal, and they're all equally effective when we're thinking about the treatment of athlete's foot. The allylamine treatment, or terbinafine, is a reasonable option when azole failure occurs. And we talked about that in the last slide. So you fail the azole, like the clotrimazole, then you can transition over to the terbinafine. To finish up this chapter, we're going to touch a little bit on local anesthetics. Local anesthetics are used as topical or site-specific numbing agents. They are available in a variety of dosage forms, such as gels, ointments, sprays, or injections. Oftentimes, we will combine local anesthetics like lidocaine with epinephrine, which is a vasoconstrictor. And the reason we combine these things is that the vasoconstrictive activity of the epinephrine allows us to prolong the action of the anesthetic. The vasoconstricting effect decreases the systemic absorption of the local anesthetic, so we really get that targeted site-specific numbing agent that we're trying to achieve when we use a local anesthetic. As a note though, epinephrine-containing products cannot be used in area of the bodies such as tips of the fingers or the toes, because we are then putting the patient at risk for excessively decreasing circulation to that area. So epinephrine has a pretty quick on-off, but as a rule of thumb, if you ever go to the ER, you're going to know that they will, if they have to numb the tip of your finger, maybe to do stitches, they're never going to use epinephrine or a vasoconstrictor there because you have limited circulation to that area anyway, and we don't want to cut it off completely. We will divide local anesthetics into two groups, the esters and the amides. Allergies to amide agents is rare, and the amide agents are generally more clinically useful. An example of an intermediate acting amide is lidocaine or xylocaine with or without epinephrine. The onset of action for lidocaine is less than 2 minutes, and its duration of action is roughly 30 to 60 minutes. This medication, when applied topically, can be used subcutaneously for IV starts. We will inject a small part into the vein that we intend on starting the IV. We use it in a gel formulation, either in the office or in the emergency room, prior to stitching up an area. And sometimes we will use this in a patch form for pain relief. So you may be familiar with lidocaine 5% patches, which are applied to exert a topical effect in a multimodal pain approach for patients. Sometimes we can use lidocaine as well as an infiltration into a local area like a nerve block to provide some numbing relief there. An example of a long-acting amide then is bupivacaine or marcaine. Again, can be used with or without epinephrine. The onset of action for bupivacaine is 5 minutes with a duration of about 2 to 4 hours. We will often see marcaine used as a joint injection to provide relief for joint pain. That wraps up today's topical products or topical agents PowerPoint. So to finish up this week, I'd ask you to move to the next PowerPoint of eye, ear, throat, and mouth agents. Feel free to post any questions you have about this topic to the discussion forum in Moodle.